Welcome to this continuing medical education presentation. The title of today's presentation is a laboratory-based testing for Lyme disease at a national reference laboratory, a 7-year experience. My name is Elizabeth Lee-Lewandrowski. This study was done and published with a colleague of mine, both from Massachusetts General Hospital and from Quest Diagnostics. It is published on American Journal of Clinical Pathology in June 2019. Learning objectives. Participants will be able to describe the relative frequency of a Lyme disease case reported to the CDC across different regions of the United States. Participants will be able to describe the CDC criteria for the laboratory case definition of Lyme disease and the limitations of currently available testing. Participants will be able to describe trends in the frequency of Lyme disease cases over time and the changing national epidemiologic and demographic of Lyme disease across a different region. The faculty is me, Elizabeth Lee-Lewandrowski, MD, PhD. I have academic appointment from Harvard Medical School. I am assistant professor at Harvard Medical School, and I am a scientist, clinical chemist at the Massachusetts General Hospital. I have no financial conflict of interest. There's no off-label use of antibiotics in my presentation and in my study. Outline of presentation. Background information from the CDC. Regional data from Massachusetts General Hospital. National data from Quest Diagnostics. Background information from CDC. This dot map has shown reported cases of Lyme disease to the CDC in 2018. Lyme disease once was perceived as a regional disease, mostly in the upper Midwest and the New England region. Now it is reported in all 50 states with a regional concentration. Some low incident states may reflect cases acquired from elsewhere. This bar chart represents the reported cases of Lyme disease to the CDC. The reported cases has increased significantly from 1997 to 2017. The light shaded bars are probable cases. The dark green shaded bars are confirmed cases. These are the cases, again, are reported to the CDC only. CDC laboratory criteria for diagnosis. A positive culture for the B. bodolferi. This is rarely performed. Or a positive standard two-tier test, which is a positive or equivocal enzyme immunoassay, EIA, or immunofluorescent assay, IFA, followed by a positive IgM or IgG, Western immunoblot. The reason this is called a standard two-tier test, because later on you'll see I will present a modified two-tier test. A positive single-tier IgG Western blot test for Lyme disease. All three are standard tests from CDC criteria for diagnosis. CDC Western blot interpretation criteria. A positive IgM result requires at least 2 of the 3 bands. The following 3 bands listed here are the 3 bands. Had 2 of them present in order to call a positive IgM. a positive IgG result requires the presence of 5 of the following 10 bands present to be called a IgG positive by CDC Western blot interpretation criteria. Now, this is one I mentioned, the modified two-tier testing for Lyme disease. This is, in July 2019, FDA cleared several Lyme disease serologic assays, allowing for an EIA rather than Western immunoblot assays as the second test in the Lyme disease testing algorithm. When cleared by FDA for this purpose, serologic assays that utilize a second EIA in place of the Western immunoblot assay are accepted alternatives for the serologic diagnosis of Lyme disease. Of note, not all EIAs are FDA cleared for this purpose. So following is the reference. People can go to the website to look for which are the specific EIAs are cleared by the FDA for the purpose the modified two-tier testing. This is the schematic algorithm for the modified two-tier testing for Lyme disease. Initially, use a first EIA. If it is negative, then no additional confirmation test is needed. If it's positive or equivocal, a second tier EIA is needed for the confirmation test. If the second tier EIA test is negative, then it is negative by definition. If it is positive or equivocal, then it is positive by definition. Of note, on Lyme disease, many cases diagnosed clinically without lab testing. A negative test early in infection do not exclude Lyme disease. Many Lyme disease cases are unreported. Therefore, laboratory test data underestimate the number of cases of Lyme disease. Lyme disease is more common than previously reported. Hinckley and colleague in 2008 has published a study titled Lyme Disease Testing by Large Commercial Laboratories in the United States. They gathered the data from 7 large commercial laboratories, reported the type and the volume of Lyme disease testing nationwide in 2008. They reported the percentage of a positive test for 4 Lyme disease endemic states: Connecticut, Maryland, New York, Minnesota. They reported the 7 large commercial laboratories performed approximately 3.4 million Lyme disease tests on approximately 2.4 million specimens nationwide. From this study, they estimated the frequency of infection varies from 10% in Maryland to 18.5% in New York. Sorry, 18.5% in Minnesota. They estimate infected patients about 240,000 to 444,000. This is 8 to 14.8 times greater than the 30,000 reported cases to CDC per year. Note, this estimation of 240 to 440,000 are derived by calculating the infection rate cited from the Maryland 10% and the 18.5% of the Minnesota multiplied by the 2.4 million specimen tested nationwide. The economic impact, the 3.4 million Lyme disease tests estimated cost $492 million by the 7 participating labs in 2008 nationwide. Bear in mind, this is only the 7 lab in the study. Then there's other laboratories had done many tests are not included in this study. Each year, approximately 30 CDC on the estimated incidence of Lyme disease states each year approximately 30,000 cases of Lyme disease are reported to the CDC by state health departments and the District of Columbia. However, this number does not reflect every case of Lyme disease that is diagnosed in the United States every year. Recent estimate using other methods, I presume is from the Hinckley study published methods, suggest that approximately 300,000 people may get Lyme disease each year in the United States. Now let's move on to the regional data from Massachusetts General Hospital. Massachusetts General Hospital is located in Boston, Massachusetts. Hence, it is in the Northeast, which is a cluster heavily infected by the Lyme disease. My colleague and I had published a paper in American Journal Clinical Pathology in 2018 titled Laboratory Testing for Tick-Borne Infection in a Large Northeastern Academic Medical Center, an 11-year experience. We look at the Lyme disease testing at the Mass General. We look at the volume of different type tests from 2006 to 2016. Both the EIA and Western blot testing has increased significantly from 2006 to 2016, whereas the PCR testing is rarely used. Now, the volume and the positivity of the EIA from 2006 to 2016 has increased tremendously, and some years are worse than others. You can see in the 2013, there are 2,000 cases of positive results. Now, this slide shows the volume and positivity of a Western blot testing for the 11 years, and it also has increased tremendously. Now let's move on to the national data from Quest Diagnostics. My colleague and I had published the data. The colleagues are both from Mass General and from Quest Diagnostics. The title of this publication is called Laboratory Blood-Based Testing for Lyme Disease at the National Reference Laboratory. It is published on American Journal Clinical Pathology in 2019. Quest Diagnostics is a large national diagnostic testing company in the United States. It serves the hospitals, patients, and physician offices. Quest Diagnostics perform testing as it is ordered by physicians. Therefore, several combinations of serologic testings are possible, including 1, a standard 2-tier EIA followed by Western blot confirmation when EIA is either positive or equivocal. 2, both an EIA and the Western blot, regardless of the result of the EIA, if so requested by the ordering physician. 3, A Western blot alone, usually, but not exclusively, in the setting where a screening EIA was performed at an outside institution for an EIA alone. This table shows the positive test result by year over the 7-year study period from 2010 to 2016. There are 5.2 million tests were performed. Among those, 593,000 positive results, which is represent 11.3% the positivity from this cohort of a volume of other tests. In 2016, it has a sharp increase, positive, total positive. It's 100,000 positive, result in 13.3% rate of positivity. This table shows the average monthly positive rate over 7 years. Here is from January to December. The testing value and the positive results are seasonal, with a peak in summer months, in June, July, and August. However, significant testing occurs in the winter months, with many positive results as well. You can see test order and positive test results occur throughout the entire year. So this is not just a summer months disease. This table shows total Lyme disease tests positive rate over 7 years in high incident states. 85.3% of positive test results came from 14 states. And you can see here, New York has the greatest number of tests ordered and the positive test results. When we normalize this number by population for each of the states, and Connecticut had the highest number of tests, 130 per 1,000 population, and it has the highest number tests per 1,000 people, 19.8. It also has the highest rate of positivity, 15.2%. This table represents the low incidence states. Many states has only a small number of tests and the positives. For example, South Dakota, over the 7 years, only had 463 tests ordered. And among that, so only 30 positives. So it is average 4.3 cases per year. Some of these cases could have been acquired from other states. This table shows the Lyme disease tests and positivities by gender. Female had more tests and more positive results. But male has a slightly higher rate of positivity, 12.4% versus 10.5%. The odd ratio is 1.18. This table shows the positive result over 7 years by age. Positive tests observed in all age groups from less than 1 year old to greater than 60 years old. In children and young adults, it has a higher rate of positive result. It ranged from 11.5 to as high as 18.7%. In older and middle-aged adult, it has higher volume of testing and has a greater number of positive results. But the rate of positivity is slightly lower than the children and young adult. PCR, the volume and positivity rate by year. In contrast to the serology, PCR is rarely used, and PCR is rarely positive. Here you can see in 7 years, there's only 64,000 tests being ordered. Among that, only 57 has a positive result or detected the bacteria by PCR. This reflects a narrow window for active spirochetemia in Lyme disease. A picture worth 1,000 words. And the most amazing data come from our study shown in this slides. This shows the changing demographic of Lyme disease positivity in the United States. It's displayed in the forms of a heat map. In figure A is 2010, figure B is 2016. You can see in figure A in 2010, only the upper Midwest and Northeast are lightened up. The rest of the country are pretty pale and pretty cool. Whereas in figure B, you can see, in addition to the upper Midwest and Northeast, the rest of across the country are many states are lightened up and hot. So this shows Lyme disease is becoming more common in states that traditionally had a low incidence of infection, such as California, West Coast, Texas, Florida. In California, testing had increased from 772 tests in 2010 to 3,000 cases, with an increased rate of positivity from 4.5% to 11.4%. In Texas, testing increased from 8,800 tests to 13,500, with an increase in the rate of positivity from 7.7% to 12.1%. In Florida, testing increased from 19,400 tests to 35,700, with an increase in rate of positivity from 7.9% to 11.4%. Conclusion: Lyme disease is significantly underreported. It is 10 times more frequent than CDC reported cases. Lyme disease occurs in all age groups and in all regions of the country. Males and females are roughly equally at risk. Lyme disease is regional, but a significant number of cases are diagnosed in winter. Lyme disease is seasonal, but a significant number of cases are diagnosed in the winter months. Demographic of Lyme disease is changing. A greater rate of infection in traditionally low-risk states. A positive test results are only a proxy for actual number of infections, but do provide an index of a change in Lyme disease frequency over time. The changing demographic finding is impactful, as you can see. If from only a few states in 2010 to pretty much all 50 states in 2016. And so we should increase the general population awareness of Lyme disease prevention in those traditionally low incident states. We should increase clinician awareness for diagnosing Lyme disease and other tick-borne infection in traditionally low incident states. I guess this is the essence of the talk, increase the awareness. So we don't want to thinking, oh, I live in California, I live in low incident states. the clinician can tell you, no, you don't have Lyme disease because we don't have it. So from this study that we can increase both from the patients and clinicians in our awareness. The list of reference, here's my list of reference from my presentation. Thank you for joining me for this session, and thanks my collaborator from Mass General and Quest Diagnostics for this study. Goodbye.